Thank you, Peter, for a very kind introduction. It is wonderful to be introduced by an old friend who has made so many wonderful contributions to our understanding of how cells work and how sometimes they don't. And I think that's what we're here to talk about for the next couple of days, is the ways in which our new discoveries about the molecular basis of illness and the risk for illness can be implemented in the practice of medicine in a way that will provide real benefit in terms of outcomes and, goodness, maybe even reduced costs, which is something that's on a lot of people's minds, and with good reason. We really do have a problem here, as you all know, in terms of the way in which our healthcare costs have been gradually increasing, not so gradually actually, and are aimed for something totally unacceptable in terms of 20% of our GDP by 2018 if we don't do something. And obviously a lot of people in this town are trying to do something, and that's on all of our minds. Can personalized medicine play some role in this, and what role does the NIH have to play in achieving that kind of bending of the curve that we all anticipate is going to be necessary? Well, certainly NIH's mission fits well with this. If you go to our website and ask what is the mission of the NIH, science in pursuit of fundamental knowledge about the nature and behavior of living systems and the application of that knowledge to extend healthy life and reduce the burdens of illness and disability. I also have to say, before we get directly into the personalized medicine focus, that there's another area of great interest right now in terms of NIH research and in terms of healthcare reform that some people have seen as potentially conflicting with the personalized medicine agenda, and that is comparative effectiveness research. So I thought I'd spend a couple of minutes right at the outset saying something about this. Comparative effectiveness research is defined in a very careful definition by the Federal Coordinating Council, whose report here you can read if you'd like, came out at the end of June. Basically is the conduct and synthesis of research comparing the benefits and harms of different interventions and strategies to prevent, diagnose, treat, and monitor health conditions in real-world settings. A very carefully crafted definition. And so this is not all of clinical research, of course. If you're starting a clinical trial to test a brand new therapeutic against the existing one, that would not be called comparative effectiveness. This really is to look at things where you have some sense that things work and you're trying to assess which one works better. The goal of CER at NIH, to conduct research, to conduct training, to support centers, and also to support behavioral economics, to be sure we understand better how to take these findings coming out of such research studies and increase their uptake. Things that we are funding as part of the Recovery Act that fall into the CER umbrella include things like a Center for Comparative Effectiveness Research in Cancer. I'll mention a specific project in a little bit that's supported through this. As comparative effectiveness of things like breast imaging strategies, interventions for chronic pain, fecal testing versus colonoscopy for colon cancer screening, surgical versus medical management for atrial fibrillation, and a large program to set up an autism spectrum disorders research registry, and there's a very long list of such projects now supported through ERA. The reason to bring this up at this meeting, because this is not officially about CER, but it's about personalized medicine, is to ask the question, is there a potential collision here? As phrased in this article by Garber and Tunis, does comparative effectiveness research threaten personalized medicine? Put more explicitly, by lumping people together and testing large numbers of individuals with intervention A versus intervention B, and then drawing a conclusion that intervention A worked better, does that mean there are a few people in the intervention B category who actually got a much better outcome because of their personalized situation, and that's going to get lost in the wash by simply considering everybody to be equivalent, which we all know they are not? The antidote to that seems pretty straightforward, that if you're going to be conducting personalized medicine based comparative effectiveness, you need to be sure you are doing appropriate genotyping to look for subsets of individuals who may have a response to a therapy which in the overall average seems slightly inferior, but for that subset might have been considerably superior. And there's some tricky aspects to that in terms of doing the power analysis about your ability to detect such subsets, which will depend considerably on whether their benefit is dramatically better or whether just a little bit. And you can imagine prediction. If it's just a little bit and you have a modest size sample, you may have a hard time identifying that that particular subset had a slight advantage. But still, I think we do need to keep our eyes on the goal here in comparative effectiveness research and not lose all that we have gained in terms of progress in understanding how individuals differ and how that can be factored into better diagnostics and preventive strategies. So what's personalized medicine? Well, using an individual's genetic profile and individual information about environmental exposures, let's be clear, it's both, to guide decisions made in regard to prevention, diagnosis, and treatment. This knowledge, if appropriately evidence-based, can help healthcare providers select proper medication or therapy and administer it using the proper dose or regimen. And certainly the genetic part of this is being advanced through data and technologies that arise directly from the Human Genome Project, including GWAS, which I'm about to talk about, and DNA sequencing, which I will also mention. So what's GWAS? Well, GWAS is this effort, which is sort of a natural follow-on to the human genome sequencing effort, is to define the variation in the human genome and then to identify which variants are associated with disease risk. An important part of achieving that kind of power to survey the whole genome looking for such variants was provided by the Hapmap Project, a project I had the privilege of leading that followed very quickly on the heels of the original sequencing of a reference human genome. The Hapmap Project identified the majority of the common variants across the genome in about 300 individuals, and that has now been greatly extended by additional work since then. So if there is a variant in the human population that has a frequency of 5% or greater, it's extremely likely we know about it already. And a more recent project called the 1,000 Genomes Project, which is sequencing 1,000 individuals, actually it's going to be more like 2,000, will drive that number down to about 1%. So pretty soon we will have a very good grasp of the variations in the human genome that have frequencies of 1% or greater. Obviously that doesn't include those rare variants that may only affect a few people. It will be essential to focus specifically on individuals that have particularly severe forms of a common disease or particularly early onset or particularly strong family history, because they may be more likely to be carrying one of these low frequency variants with intermediate effect. To do that kind of analysis really then brings us into the need to carry out not just SNP genotyping across the genome, but DNA sequencing, looking in every nook and cranny to try to identify what might be accounting for that missing heritability. Again, the Recovery Act made it possible to take these new capacities in genome sequencing and begin to apply them to a variety of topics, and that includes cancers, which I'll come back to in a minute, heart, lung, and blood diseases. Participants in Framingham, for instance, now having complete genome sequencing included in that very powerful and long-standing study. And autism, trying to sort out what are the genetic contributions to this very puzzling disorder. If you add up the funding that's gone to DNA sequencing from ERA, it's the equivalent of complete genomes at high coverage in about 2,300 people, which are early indications that an alternative here might be even more rapidly applicable, at least to some situations, and that's to focus on the exons, now referred to as the exome, all of the exons. It's only about 1 or 1.5% of the genome that codes for proteins. And it is possible, using a variety of hybridization-based methods, to actually select out the exons from a DNA sample and sequence those specifically, instead of doing the whole thing. So in terms of diagnosis and risk prediction, I think it's fair to say that already some of these technologies are finding their way into the practice of medicine, as just described in these two examples of identifying rare variants responsible for childhood illness, but perhaps on a larger scale by identifying those common variants that predispose certain individuals to higher risk. We have the chance, not yet I think demonstrated in most instances by rigorous research, to optimize the way in which we practice prevention, so that a person who's found to be at higher risk for colon cancer than the average might very well benefit from beginning colonoscopy at an earlier age. A big area, of course, of personalized medicine expansion is in this possibility of using diagnostics for somatic changes that are going to be predictive of outcome in the case of cancer. So that's diagnosis and risk prediction, but pharmacogenomics, which is a topic that will be discussed in more detail at this meeting, is in my view also a very exciting and rapidly moving phase, and personalized medicine should point to this, I think.